Before I start, I want to answer your question that you asked. What will you do with a patient with moderate MR in spite of medical treatment? That's a very good question. I can't show you the data.
Okay.
We have done an analysis of patients who have moderate MR and like the reshape from MITRA-FR study showing no mortality benefit, but we will show you an improvement in quality of life.
Okay.
You will see that data coming out in a couple of weeks. So I think there is benefit for that group. So we're going to talk about Mitraclip after failed surgical repair, approaches and challenges. Recurrence of MR following successful surgical repair can occur. Redo surgical repair is often challenging and poses a higher surgical risk. And many of these patients therefore undergo mitral valve replacement. And Mitraclip is a safe and effective option in some of these cases. So I'm going to show. So the approach is that you have to look whether they have an adequate mitral valve orifice, if the pathology is localized, and ring should not be in the way of a repair. So these are some of the case selections. Failed annuloplasty, like progressive tethering or ring dehiscence. Failed leaflet repair, new prolapse of flail, disconnection of an artificial cord, post-surgical repair, systolic anterior motion of leaflets, sometimes mixed pathologies after repairs. So see, these are some of the cases that you can see and actually probably address with the Mitraclip. So here's an example of a patient who presents with, let's see if it plays. So the patient presents with severe mitral regurgitation few months after the surgical repair with cabbage and ring annuloplasty. And I looked at the echo, I couldn't understand what it is. And I see this severe MR, and I see something is sticking in the middle. And then we did a 3D and we can see that the ring has come off the posterior wall. So it's right in the middle of the valve. So we said, what are we going to do with this? We can't drag the ring out. The redo surgery is quite difficult in a patient who's had cabbage already in before. It's ischemic MR. So we tried to consider for a Mitraclip. And the problem was, if we do a Mitraclip, the ring is going to come in right in front. So we decided, we needed a space in the anterior side. So we decided to approach from the anterior side of the valve. And so therefore we had to do a transeptal puncture, which had to be superior and mid-fossa and posterior, allowing it to be more like a wall hugger. And therefore we went from the top. And you can see that we managed to go down to the anterior side. We grasped the leaflets very effectively. And then you can see over here, there is a good double orifice and actually completely trace MR. So you can see that here's an example of a case with post-surgical repair ring dehiscence, which could be treated with a Mitraclip. The transmedullary gradient was only 5. The second option is a 72-year-old man who presented with acute left heart failure 10 years after robotic mitral valve repair. And you can see over here, this is this patient, and you can see there's a new acute flail of the posterior leaflet. And the valve orifice seemed to be quite adequate, and the ring that they used, the surgeon used, was not an undersized ring. And so because it was not an undersized ring, we thought that it's okay, we can actually consider it for repair. So we actually took the patient into Mitraclip. We put 3 Mitraclips in, and in spite of that, and they actually was trace MR, and the mean gradient is 5, and the patient could go home the next day. So this is an example of a patient with a recurrent prolapse and flail, which could be treated with the Mitraclip. This is a 71-year-old male who had previous coronary artery bypass surgery, underwent mitral valve repair with artificial cords and a surgical ring. And about 10 days after the surgery, the patient was short of breath and had a loud systolic murmur. When you looked at the echo, you can see there's an eccentric wall-hugging jet. And then if you look at the 3D, you will notice that there is a snap of the artificial cord. So the artificial cord has come off the posterior leaflet, and therefore there's a recurrent prolapse or flail of the posterior leaflet leading to severe MR. So we thought that this is an ideal case for a clip. So we went ahead and put one clip in the valve. There was trace MR. Both the patient and the surgeon became less short of breath. Patient was discharged home the next morning. So this is a patient with artificial cord detachment, which can also be done. This is another gentleman who had a previous mitral valve repair many, many years ago for anterior prolapse disease with an ATS band. And he had a 39 millimeter ATS band, so it was not undersized. And he had a small LVOT with multiple jets. He had actually multiple jets. So we did what we went in ahead, and you can see that there's a jet on the lateral side, there's a jet on the medial side. And because of his history of multiple myeloma, we didn't consider him for open heart surgical procedure. So we said, let's at least try to reduce the MR by trying to tackle at least one of the jets. So we went ahead and put one, we addressed, and you can see there's a restriction of the posterior leaflet and a prolapse of the anterior leaflet. And so we went ahead and put one clip on the lateral side, and then we found space and we put a second clip on the medial side, far away from the other clip. So we actually caused a triple orifice valve. And you can see over here, there's double orifice, and you can see there's trace MR. There's only one small medial jet. This lateral jet is completely gone. And over here you can see there's actually two clips. one over here in the middle and one on the side, and the adequate orifice. So you can see that even with multiple jets, you can actually use a Mitraclip procedure. This is a 74-year-old male with a previous history of mitral valve repair with a ring annuloplasty, who presents with shortness of breath. And what you see over here is a classical case of systolic anterior motion of the anterior leaflet because of cutting of the posterior leaflet, and a small residual mitral regurgitation here. So it's a combination of SAM with MR. So this patient, this is what the LVOT gradient is, and you can clearly see the typical Brockenbrough phenomena. So
3 minutes.
Severe SAM and severe MR. And so this patient was only treatment option for this patient was a mitral valve replacement. But what we did instead, we just did one clip and basically tackled the anterior leaflet and prevented the SAM and made the MR trace. So they trace MR and complete correction of SAM. And this is the gradient, which is completely elimination of the gradient. So here another example of where you can use the Mitraclip for the treatment of a complication from surgery. So the challenges are that the mitral valve orifice, mitral valve gradient, because you have to have if the gradient is high, you can't do it. There has to be adequate posterior leaflet to grasp. Ring dehiscence can interfere with the trajectory of the clip delivery systems, and the presence of the ring may make visualization of the leaflet quite difficult. So these are some of the challenges that you will encounter when you're using Mitraclip for, but it can be done in selected patients.
2
and
minutes.
If it's doable, you should try it. Redo surgery following failed surgical repair can be risky. Mitraclip is a safe and effective treatment option for selected patients with failed surgical repair. In this situation, there are unique approaches and challenges with the Mitraclip procedure. And my final cardiac surgery is a gift that keeps on giving. Thank you very much.
Well, I think that you gave us an example, a very well documented example, that we should be more proactive in sending patients to our surgeons to apply them the plastic intervention of the mitral valve, having the advantage of them repairing the results, whatever they are. Okay.
If there's no question, I can leave.
1 minute.
Any question from the audience? Yes, please.
Yes.
Very, very nice presentation. Thank you. I have one question about the role of Mitraclip in hypertrophic obstructive cardiomyopathy. You nicely shown us one example, but this was, I understood, only for SAM. could it be used just to reduce the gradient de novo?
So we have a strategy that if you have a patient with severe MR and SAM, and which is not responding to medical treatment, the first option we do is alcohol ablation. And if it doesn't work, then we just do a Mitraclip. Or if we see that it's severe SAM and MR only, then we can just do a Mitraclip. So Mitraclip is a reasonable option for treatment.
Okay.